Well, good afternoon and welcome to the 13th annual Michael DeBakey Lectureship. This is one of the highlights really of the academic season, and we're glad that you can join us this afternoon. Let me start off by thanking Dr. Robert Jackson, who you'll see later, because he's really the one who spearheads this, arranges the speakers, and helps organize the entire program. So thank you, Robert. It's a particular pleasure this afternoon because you're going to hear from one of our own. This is a mixture of outside and inside speakers, and today we're going to hear from Dr. Thomas MacGillivray. Tom is a member of our department, and he is the Chief of Cardiac Transplant and Cardiac Surgery. And so the title really encompasses a huge swath of organ transplants, lungs, hearts, as well as all aspects of cardiac surgery, both within the system and down here at Houston Methodist Hospital. He joined us from Boston, and you always say it's difficult to prize the Boston man out and get him to come south, because he did his general surgery residency at MGH, did his cardiac fellowship at MGH, had a brief stint doing research at UCSF, and has been on the faculty for many years at Massachusetts General Hospital. I always tell the story when I talked to my compatriot who was the chief of vascular surgery up there. I said, well, we're thinking about trying to hire him. He said, don't bother. He's the best heart surgeon in New England. He's born and bred in Boston, and he ain't coming down there. So after we recruited him, I saw the same person again. He said, no, really don't speak to me. No, I'm not going to speak to you because you recruited him down there. So Tom, he's a very distinguished cardiac surgeon, has continued that in Houston. He's also currently the second vice president at the Society of Thoracic Surgery. That means if he keeps his nose clean, as we say, he'll become the full president of the Society of Thoracic Surgery in 2023. He's also taken a huge interest in quality and safety, and I think that's going to be the feature of his talk this afternoon. So Tom, tell us a little bit how we can improve quality and safety. And thank you for coming.
Well, thank you very much, Alan, for that very gracious introduction. And I would like to thank Dr. Jackson for the kind invitation to speak. I am truly honored and very humbled by this invitation to speak at the Michael E. DeBakey annual lectureship. Dr. DeBakey, his legacy still stands incredibly tall. There's no physician, let alone surgeon, who has had more of an impact on cardiovascular care than Dr. DeBakey. He exemplified innovation, education, and excellence. And beyond the contributions he had in individual patient care, he was also a leader in systems of care. I don't think many people realize that he was instrumental in the development of MASH units for combat soldiers, and then in the VA system for returning veterans from combat after World War II. So I think it is fitting and appropriate that this afternoon we'll be speaking about advancing the culture of quality and safety, something I think Dr. DeBakey in this day and age would be very interested in. My disclosures, as Alan pointed out, I am on the board of directors of the Society of Thoracic Surgeons. I will be speaking about some of the STS quality initiatives. I have no financial conflicts involving the STS or other entities related to this talk. So let's start with the patient. A couple of weeks ago, a 46-year-old man presented to one of the outside clinics with severe chest and back pain. He had imaging and was diagnosed with an acute type 1 DeBakey aortic dissection. He had the dreaded free-floating true lumen, so all of the vessels going to his brain and his upper extremities were involved in the dissection. He was transferred here to Methodist. We took him to surgery. We performed a total arch replacement where we replaced not just his aortic arch, but reconstructed all of the arteries going to his brain into his upper extremities, and we did a frozen elephant trunk. We put a stent graft in his descending aorta. This isn't just a surgery. This is actually a symphony, and it's a symphony that began its composition 70 years ago by Dr. DeBakey. This operation that we did a couple of weeks ago and that we routinely do here at Methodist and other medical centers around the world are a compilation of artificial blood vessels, cardiopulmonary bypass development, myocardial protection, brain protection, intensive care. And all of it has led to taking a disease that is universally fatal back in the 1950s to now something that we can treat. And like this man, he was discharged in under 2 weeks. The impact of that kind of development of a system of care, improving care, cannot be overrated or understated, not just for what happens to individual patients and their families, but also to the communities. And it's very important, I think, that we celebrate our successes. It's also important, though, that we confront our challenges. Healthcare is a very complex entity. And in addition to providing excellent care for individual patients, it's important that we do more than that. We have to improve health care for entire populations, and we have to do it in a way that doesn't bankrupt all of our systems by reducing the per capita expenditure for populations. So how are we doing? If you look at any number of metrics of how the U.S. healthcare system does compared to other countries in the rest of the world, well, we spend twice as much money on healthcare as other economically developed countries, almost twice as much as the average country. If you look at per capita spending, almost twice as much, not only in public spending, but also private insurance spending and out-of-pocket costs. So what do we get for that money? Well, our life expectancy is the lowest of all of those countries. And for the first time in 100 years, the life expectancy in the United States is starting to drop. If you look at the disease burden, it's the highest of all the developed countries. Looking at healthcare access and quality, it's the lowest of all of those countries. And if you look at the reports of the number of patients who document either medication errors or treatment errors over the last 2 years, we're not the worst, we're tied for second worst. So, there is tremendous opportunity for us to improve the healthcare delivery system in the United States. In 1999, the Institute of Medicine, as it was called in that time, published a sentinel work called To Err is Human, Building a Safer Healthcare System. And at that time, they reported that approximately 100,000 patients per year died in the hospital as a consequence of medical errors, diagnostic errors, treatment errors, preventative errors. Currently, medical error is the third leading cause of death in hospitals in the United States. But it's important to note that their report noted that these mistakes, these errors, they're a result of faulty systems and processes. It's bad systems, not bad people, that are largely responsible for these mistakes that lead to complications and deaths. On a positive note, they were quite confident that with the appropriate leadership, attention, and the allocation of resources that we could make tremendous improvement in this problem. A couple of years later, they came out with a second report, one that was a prescription for trying to cure this disease. And they cataloged 6 aims of what healthcare should aim to be. It should be safe, effective, patient-centered, timely, efficient, and equitable. So first and foremost, it should be safe. First, do no harm, primum non nocere. And again, errors that take place, safety issues, are generally due to bad systems, not bad people. They recommended that the burden be shifted away from individual providers in trying to understand why those errors are made, and to create and maintain systems of care that will ensure patient safety. It should be the hospitals and the institutions that are held accountable, not necessarily the people who make the mistakes. The healthcare system should be effective. The old reliance on tradition and personal experience should really no longer be acceptable. We should be practicing evidence-based medicine and providing evidence-based practice. The idea of illusory superiority, or the Dunning-Kruger effect, that is, the people who need performance improvement the most paradoxically feel they need it the least. The recommendation in this report was that patients should receive care based on the best available scientific knowledge. The care should not vary illogically from clinician to clinician or from place to place. And we now have a number of tools that can help each practitioner and guide them to be on top of the best available medical evidence. There are numerous evidence-based guidelines that are available. Medical evidence, medical treatments, they change, they evolve, they get better. It's hard to stay on top of everything. Most of the specialty societies print and update these guidelines on evidence-based medicine. They can help us stay up to date not only with what evidence is currently available, but also help us weigh the level of the evidence and give us recommendations of how to practice. Evidence-based practice, that's different from evidence-based medicine. Evidence-based practice is being very aware of what our treatments do. How do they impact our patients? We, of course, do what we do because we believe in what we do. But more importantly than believing in what we do, we should be sure of what we do. W. Edwards Deming is considered to be the guru of quality improvement. He was not a physician. He was actually an engineer who was very much involved in the redevelopment of Japan after World War II, and made tremendous advancements in the automobile industry. And his quotable quote that without data, you're just another person with an opinion. Data is very important. We work within a system of care, and Professor Deming came up with his system of profound knowledge, which has to do with understanding how systems work. Whenever you make changes within a system, there will be unintended consequences. So for all of us working within the system, it's important to understand how it works and how we work within that system. Variation is inevitable, but variation is dangerous in a system. Whenever possible, it is very helpful to reduce unnecessary variation. He talks about the theory of knowledge. That is, theories are important to help us plan for how to do things better. But theories need to be tested. They need to be tested in a high, reliable way. Medicine is an art, but quality improvement is a science. At least it should be assessed by the scientific method. And perhaps most importantly is the understanding of psychology. As I said, we do what we do because we believe in what we do. Change and change management is very difficult. Understanding how to take your idea and put it into clinical practice, that is oftentimes where the biggest challenge lies. It is important to know how you are taking care of patients. It's important to look at your data. The data should be risk adjusted so you can try to determine where your patients fall on the spectrum, and then use that data to be benchmarked against local data, regional data, national data. And we'll get into a little bit more what tools are available in medicine to help us do that. Once you identify that there is an area that could potentially be improved, there are performance improvement plans that you can put into place, the so-called Deming cycle. Identify your problem, think about and create a potential solution, and then you need to test those solutions look at your results, and then if your results from your test show that there is benefit, implement it. If not, start the cycle all over again. Again, the focus is to continuously identify how you're doing and improve what it is that you're doing. Healthcare should be patient-centered. We need to be respectful of patients' values, receptive to patients' inputs. We shouldn't be delivering care based on whose office or which clinic the patient happens to walk into. Patients are entitled to receive the best care, and that involves including multidisciplinary teams. The team should discuss what the different options are available to the patient and discuss it with the patient, so-called shared decision making. And that is how we can achieve the best possible outcome. We are very fortunate Methodists. We've got, certainly on the cardiovascular side, in keeping with Dr. DeBakey's legacy, our teams have made tremendous advancements in advancing transcatheter aortic valve replacement, not just in academics, but also in individual patient care. Our heart team is a multidisciplinary team headed up by Drs. Mike Reardon and Neil Kleiman. And the real heavy lifting is done by Catherine Ruff, who is the valve coordinator. These heart teams have been very effective not only in TAVR, but coronary revascularization, transplant, multidisciplinary tumor conferences. Again, getting all the experts together to look at what the problem is and come up with the best solution for the patient. Healthcare should be timely and it should be efficient. Unnecessary delays, not only do they prolong waiting times, but they also add to patient pain and patient frustrations. It's very important that we all be good stewards of the valuable healthcare resources. And lastly, from the Institute of Medicine, healthcare should be equitable. Every person across the country should have equal access to the same quality, value-based care. Value-based care is kind of the new buzz phrase. And most people interpret that to be cost-cutting. But that's not actually the case. If you look at value-based care, value has as much to do with improving quality in how we provide that care as it does with cutting cost. And I think that what we've learned over time is the highest quality care is oftentimes less expensive than care that's associated with complications. Michael Porter, who is a Harvard Business School professor, helped in shaping, what exactly is value in healthcare. Very important that value should be defined around the patient, not the providers. And the value depends upon results, not the inputs. It's not the number of tests or procedures that you do, it's how well the patient does. And the focus is shifting from volume to value. It's not how much you do, it's how well you do that really matters. And the system should create, anyone that creates value and value care for the patients, that's how the providers should be rewarded. Not with, again, how much they do, but how well they do. And those measures of outcomes are achieved, it's how well we achieve those outcomes, not by the volume of services rendered. So, very important question. How do we define high quality care? Do we know it when we see it? Well, maybe, maybe not. I mean, there are a number of different hospital rating systems. How valid are they? These are among the 4 best known hospital rating systems: the U.S. News and World Report, Health Grades, Consumer Reports, and the Leapfrog Hospital Safety Group. It's interesting, or maybe even ironic, that there are over 700 hospitals that are stated to be in the top 100. Interestingly, no hospital in the United States is rated as a high performer by all 4 of these rating systems. And only 10% of hospitals are rated as high perform that are rated as a high performer in one program is rated as a high performer in another program. I mean, I think there's reasons for that, partly because there's generally a lack of agreement on what quality is. They use different methods and they look at different metrics. In cardiothoracic surgery, the Society of Thoracic Surgeons has really taken the lead on using data to help drive quality care. Starting in the late 1980s, the STS National Database has been accumulating very granular data from cardiac surgery that's taken place. Since that time, we now have almost 7.5 million patient records. 95% of all cardiac surgeons and all cardiac surgery programs participate in this database, from which we have a very robust database. Every year, there is a report about what the outcomes are across the data, across the country, based on that data. Not just mortality, but also morbidity and quality metrics and process metrics for each one of the index cardiac surgery operations, which comprise more than 80% of cardiac surgery operations that are performed. As I mentioned earlier, this data is risk adjusted using very high fidelity risk calculators. And for each participant, each hospital gets a report twice a year as to what their outcomes are and what their outcomes are expected to be. And again, risk-adjusted data. This data is also able to be used and benchmarked with how similar hospitals, so hospitals like Methodist that are big tertiary care hospitals with teaching programs, as well as how it's doing with cardiac surgery programs in general. From this, there's also a bedside online risk calculator. By plugging in clinical, laboratory, and imaging data from individual patients, you can get a calculation of what the predicted mortality and what the predicted morbidities are of these patients. The old foot of the bed check is remarkably accurate, but this adds a qualitative as well as a quantitative assessment of these patients. And sometimes when you do these calculations, you're surprised. There are things that you identify that you may have missed in your clinical assessment that may have you look closer to help prevent a complication or a death. These process metrics and quality metrics look at, again, mortality, things like prolonged ventilation, renal dysfunction, stroke, the need for reoperation, and infections, as well as process metrics that are evidence-based guidelines that have shown that improve not only the outcomes, but the long-term outcomes of patients who undergo heart surgery. So at Methodist, as we were looking at some of our data about 5 years ago, we noticed that we had an issue with prolonged ventilation. That is defined as patients who are on the ventilator after cardiac surgery for longer than 24 hours. Well, why is it important? I can tell you every day when I talk to patients about their upcoming heart surgery, at least one person a day tells me how concerned they are about being intubated, being on the ventilator, and being awake. So it's a patient satisfaction issue. More importantly, or equally importantly, the longer patients are on the ventilator, the more hemodynamic support they need, the more volume they need, the longer they stay in the ICU, the longer they stay in the hospital. And if you look at the Methodist data in the blue bars, back in 2015, about 12% of our patients fit prolonged ventilation, compared to like institution, which were about half that. We were an outlier with like institutions. So we put into place a performance improvement plan trying to identify how we could improve that metric, and more importantly, how we could improve how we took care of our patients. We put into place an algorithm after bringing together cardiac surgeons, cardiologists, pulmonologists, intensivists, to come up with a process by which we evaluated patients to try to identify those patients who were at risk for being on the ventilator longer than they might otherwise be. We also looked at the way we weaned patients from the ventilator, and we were using systems that had become somewhat outdated. We had a very methodical and iterative approach to how we weaned the ventilator. We'd turn the ventilator down, we'd check blood gases, we'd check ventilatory mechanics. What we've found, or what others have found, is that that really didn't make it safer to extubate patients. All it really accomplished was keeping people on the ventilator longer than they needed to be. We simplified the process, and we empowered the bedside nurses in the ICU and the respiratory therapists. Once the patients were awake and alert, and they could breathe spontaneously, as long as they had stable hemodynamics and they were not bleeding, we looked at their gas exchange. If they had an oxygen saturation that was greater than 94%, on 50%, we'd start the process to extubate. As long as they could handle 20 to 30 minutes of CPAP, and the respiratory rate wasn't too fast, they could and they would be extubated. It took a bit of change management to get everybody to buy into this. The concern was that we were going to be putting patients at risk. Well, when we looked at our data, what we found from the time that we initiated it in 2015, there was an incremental decrease in the amount of prolonged ventilation that we had in patients. We went from being an outlier of being too long to being an outlier of being, we had half as much patients having prolonged ventilation as like institutions in other cardiac surgery programs around the country. This was a proof of principle that performance improvement projects worked. Not only did we have patients who were not on the ventilator too long, that with this process, over 80% of our patients got extubated after cardiac surgery in under 6 hours. And that was without increasing the incidence of patients needing to be reintubated or running into problems. Using these same kinds of methodologies, we've used it to look at other issues that we've had. We currently are using a similar kind of algorithm to identify patients who are at risk of developing renal dysfunction and renal failure, again, bringing together all of the people who can bring areas of expertise in identifying these patients. We're using urine serologic markers to identify patients who develop a renal injury, either in the operating room or in the intensive care unit. We've started to standardize or try to reduce the amount of variability in how patients' hemodynamics are being managed by using very simple, well-established hemodynamic management guidelines. Things like blood sugar control, not just in diabetics, but in non-diabetics. There's excellent data to show that controlling people's blood sugar during heart surgery and after heart surgery is significantly associated with reduced mortality, reduced morbidity, reduced wound infection rates, which is also associated with reducing hospital length of stay and improving long-term survival. We took this information, we developed a performance improvement plan, and the intensivists, the nurses, the pharmacists up in our intensive care unit, within a very short period of time, have put into place a very effective process to maintain and keep our patients' blood sugars under good control. It takes a tremendous team to win, to be successful. Here's a nice picture of the Astros after they won the World Series in 2017. But I want you to look at that photo, and instead of seeing pitchers and catchers and infielders and outfielders, I hope you can see nurses and pharmacists, intensivists, cardiologists, occupational therapists, physical therapists. Those are all people on our successful team to improve the care of our patients. We're deeply indebted to our Department of Quality, Erica Rendon, who heads up the cardiac surgery quality program, and below her are a list of a number of quality and performance improvement projects that we have underway, not only to try to improve mortality, but also length of stay, patient experience, prolonged ventilation we talked about, decreasing post-op renal failure, and multimodal pain management therapies. And we're deeply indebted to all the hard work that Erica does to help us improve the care of our patients. Besides improving the numbers, why is it important? Well, complications are expensive. They cost patients lives, they cost money. In Virginia, the Virginia Cardiac Quality Services Initiatives, so all of the cardiac surgery programs in the Commonwealth of Virginia grouped together to collaborate. They all shared each of their hospitals' STS quality data, but they also agreed to share their financial data. All of the hospitals showing their financial ledgers to look at how they could link quality and cost. This is a report out of that project showing in patients undergoing coronary artery bypass surgery with each of a major complication, whether it be an infection, a stroke, renal failure, with each subsequent complication, the cost of the care goes up geometrically. It essentially doubles with each of those complications. And it's interesting. It's not just the bad mediastinitis or the stroke, but ironically, the most costly of all the complications was prolonged ventilation, not because of the healthcare impact on those patients, but just how prevalent it was. And over a period of 10 years, it was estimated to cost the Commonwealth of Virginia almost $60 million. So by paying attention to improving prolonged ventilation, improve the quality of care, decrease the cost of care. That is value-based care. So more and more, the payers are moving to pay for performance. And I'd mentioned earlier, it's not how much care you provide, it's how beneficial, what the quality of the care is that you provide. CMS has already put into place the merit-based incentive payment system, where it will reward high-quality programs, and there'll be financial penalties for low-quality programs. And I guess it depends whether you're a half glass empty or a half glass full kind of person. I see this as an opportunity. I see this as a win-win. The focus isn't on the money, the focus is on the quality. We all want to provide the best care we can for our patients. And looking at programs that perform the best care, the best quality, and at programs that do that at a lower cost, there are going to be winners and there are going to be losers. I think the biggest winners are going to be our patients. In addition to the outcomes being looked at by the payers, there's also the issue of public reporting. And in cardiac surgery, it's got a pretty interesting history. Back in 1989, when coronary artery bypass was in its heyday, I would say, certainly in terms of the number of patients getting CABGs, the New York State Department of Health thought it would be very important that they try to get a handle on cardiac surgeon-specific outcomes. They never intended this information to be made public, but there are unintended consequences. A magazine in Long Island, Newsday, sued the New York State Department of Health under the Freedom of Information Act. This information, they thought, should be in the purview of the public. And in so doing, Newsday published cardiac surgeon specific outcomes. It was risk unadjusted data, as on the front pages of not just Newsday, but many of the newspapers in New York. And shortly thereafter, other states like Massachusetts and Pennsylvania followed with reporting not just cardiac surgery, but also cath lab PCI data. Other entities like the STS, the ACC, and CMS try to get a handle on it by looking at risk-adjusted data to, again, try to make sense of it. Public reporting, I mean, it has its pros and its cons. Part of the problem is that the data that's used can be distressed at best and distrusted at worst. Administrative data is notoriously incomplete and at times inaccurate. Do you look at unadjusted data, which basically would potentially have people in programs do risk aversion, or do you use risk-adjusted data? The problem with risk-adjusted data is it's confusing, not just to patients, but also to payers. One of my colleagues when I was in Boston took a bunch of risk-adjusted data based on individual cardiac surgeons, and he showed it to physicians and nurses and asked them, based on this data, which surgeon would you choose to do your heart surgery? And almost universally, they chose the surgeon with the worst outcomes because the risk-adjusted data was so complicated to understand. Other problems with public reporting is public humiliation. There have been providers and programs across the country who have lost their jobs and lost their certification. And this leads to risk aversion and risk avoidance. And if you look at what happened after New York started presenting surgeon-specific data, the number of high-risk heart surgeries that took place in the state of New York went down. This is a bar graph from a report from the Cleveland Clinic. And the bars on the left were the outcomes of patients from Ohio in the white, black, from New York in the black, in other states before the public reporting, and in the set of bars on the right after public reporting. So the number of patients from New York that were operated on at the Cleveland Clinic for heart surgery, their mortality rate went up significantly compared to the other patients that came from Ohio and other states and other countries, suggesting that the patients that came to them from New York were much higher risk patients because they were not being offered heart surgery in New York at that time. This is data from Massachusetts. We're looking at PCI data, and the graph on the bottom is Massachusetts, the graph that had public reporting of PCI outcomes, and the graph on the top with the circles comparing it as controls of states that didn't have public reporting. And after public reporting went into place for PCI in Massachusetts, the number of high-risk PCIs went down. The purpose of this isn't to not take care of the sickest patients. The purpose of this is to try to identify how we can better take care of the sickest patients. There are advantages, there are pros to public reporting. Some people would argue that there's a moral imperative. I'm personally not so sure about that. But I do think that transparency and accountability is good. It allows patients and payers to make the best decisions. And equally importantly, it helps programs identify where they have opportunities to improve. The goal is to bring the low performers up, not bring the high performers down. And as I mentioned, the goal is not risk aversion. It's to identify patients who are at risk and to do what you can to mitigate that risk. But that being said, I mean, there is real concern. The concern is that, are we sacrificing the future for the sake of the present by focusing on the numbers rather than the patients? And might training in the future be compromised? Are we going to train physicians and surgeons by discouraging them for taking on high-risk patients and avoiding higher-risk procedures? I think not. I think that in our specialty, in our profession, throughout history, intrepid physicians and surgeons like Dr. DeBakey have greatly advanced the care of medicine and the care of patients and populations of patients because they had the courage to innovate and act when the high risk of doing nothing for the patients was unacceptable. I think that spirit still exists, but I think we can do it by advancing the culture of safety and quality. That doesn't require that we cower from challenging patients or difficult problems. I think just the opposite. It's important that we are strong enough and we have commitment enough to learn from those patients that didn't do as well so we can take better care of our patients in the future. These last couple of years have been very challenging, and it is also very humbling, and I'm very proud to be part of an incredible organization like Methodist. Our hospital system pivoted when COVID started. We all became experts in taking care of patients with COVID, whether it's developing different strategies, whether it was personal sacrifice or putting yourself at personal risk. It was amazing to walk around the different units and see nurses and therapists donning and doffing PPEs, all to take care of these very sick patients. I think that the challenges that we have been facing in this pandemic are as great, if not greater, than the challenges that were faced in the 50s when we're trying to figure out how best to take care of aortic dissection. I think both of those successes should be celebrated, and we are very fortunate to be part of this incredible organization. So in summary, I'd like to say that there is real opportunity, I think, for us all to improve safety, quality, equity, and cost. The focus should be on the patient in providing high quality and safe care. We can do that by practicing evidence-based medicine and evidence-based practice. The culture of quality and safety, it requires rigorous assessment of our processes and our outcomes. As I mentioned, the practice of medicine is an art. The science of quality improvement requires scientific methodology. We are shifting away from volume to value and higher quality care at lower cost. And I think we all have an opportunity to participate to transform the way healthcare is practiced. And in the words of the great Wayne Gretzky, we want to skate to where the puck is going, not to where the puck has been. And with that, thank you very much, Dr. Jackson, and to all of you for the kind invitation and for your attention during this address. And I'm very happy to answer any questions.
Tom, thank you so much for an outstanding lecture. I know Dr. DeBakey would have been proud to have heard it. He's probably listening to it in his own way. I have a couple of questions. Hopefully they're just soft pitches. What's your vision for the future of artificial intelligence in improving our quality and patient safety? I have sort of a Cro-Magnon brain and a little bit of Neanderthal, and I have trouble really absorbing all the data. Tell us a little bit about your vision of AI for improving surgery.
So, that's a great question, and I'm not sure. I obviously don't have the answer. I don't know a lot about artificial intelligence. But I do think what I do know about it is I do think it will be a valuable tool, not to make the decisions for us, but to help clinicians make decisions using it. As you mentioned, I mean, the amount of data that we have, I mean, the turnover of medical information and medical knowledge, I mean, it is impossible for anyone, even an expert, to keep track of what's going on in their particular subspecialty, let alone in medicine. And I do think that's where artificial intelligence can really make a difference. It can help us with things like these risk calculators, that rather than someone sitting down with a number 2 pencil and a yellow legal pad trying to write down the creatinine and what the ejection fraction is, that should be information that's readily and immediately available to us at the bedside. Give us that information that will help us make the best decisions. I don't think we want to abdicate the responsibility of making those decisions. I think that we owe it to our patients to take the best information that we have to make the best decisions that we can in their care.
And it's clear that the data has really improved quality and patient safety, especially with cardiovascular surgery.
Yes, I mean, many of the methods and methodology that I talked about were specific to cardiac surgery, but I think the principles can be applied broadly. And I think that I do think, in keeping with what Professor Deming said, I think data is very important. We don't want to care for the data. We want to use the data to help us care for our patients. Without data, you know, it's hard to know how well you're doing.
I love the quote, "Without data, it's just an opinion." One other thing, I know that robotic surgery has sort of entered the field in the last several years, and your first few slides, you know, showed the patient was obviously open. What's your vision of how robotic surgery is going to improve quality and patient safety in the future for cardiovascular surgery?
I mean, it's the technology that exists in cardiac surgery and other fields of medicine I mean, it's really amazing. I mean, advanced imaging as well. Robotics have made, I mean, a tremendous impact on different kinds of surgeries already. Cardiac surgery has been a little bit later in its development, but is now being performed more and more commonly around the country, including we're re-establishing the robotic program in cardiac surgery here at Methodist. Nobody wants to have open heart surgery. I mean, there's not a long line out our door saying, "Sign me up for that big sternotomy." And I do think that if you ask patients what they want, I mean, they want to get better, they want to feel well, but they also want to do it in a way that's not going to be disabling, and even in the short term. If you can accomplish the same outcomes in something that's smaller, easier, less invasive, patients may even, and have, chosen that option over something that may be more durable, more longer lasting, if it involves more temporary disability. So I think that the future for robotic cardiac surgery is very big.
That's outstanding. Well, thank you so much again for the terrific lecture, and thank you for coming down from New England and heading up our program. We're very glad to have you.
Thank you very much, Dr. Jackson. It's a pleasure.
Thanks so much.